Hello, Raju. How are you today? And what is on the agenda?
Michael, an interesting story I have for you. I was actually browsing PubMed for articles on diagnosis of Sjogren's syndrome in children. And there was an article on salivary electrolyte estimation. And a cross reference led me to this systematic review on saliva testing for autoantibodies. And I thought that this concept was quite unique.
Really interesting, Raju, even if we don't use it in practice, because for children, the collection of sample is very easy, friendly for the child. You don't need a trained staff, you don't need a hospital, and so it could reduce the number of visits. Only warning I would have is that what is important in autoantibody measurement is not only measurement but also interpretation, and we really need to keep the interpretation in the hands of people who are really trained for this and will not overdiagnose some autoimmune diseases.
Very true. Additionally, you could store and ship samples from your home, reducing the rush on the clinic or the hospital. Michael, saliva testing came into vogue since the 90s for HIV and more recently attracted a lot of attention during the COVID pandemic. There are a host of other uses from oral cancers, infectious diseases, sugar monitoring, periodontal disorders, drug level monitoring, and even testing for drugs of abuse.
This is impressive, Raju, but I have some concerns about limitations because saliva is not serum. So is really the relationship between both really the same? And also what we measure in saliva are constituent of the saliva. Is it also good for other measurements that we do in the serum? But I agree, because of the simplicity of this process, it attracts us greater attention and let us see the sum and substance.
Yeah. And additionally, sometimes, even the food substances that we ingest may impact testing. But this particular review, what the authors did was they used appropriate search terms to identify articles on autoantibody testing in saliva, English language articles which had tested humans, and each paper which had at least 10 patients enrolled with a detailed description of the techniques used were the criteria used for shortlisting the papers. Out of 170 articles that they first sort of picked out from the published data, 18 articles were shortlisted and the data was extracted and summarized, and this included the study design, the population type, the number of subjects studied, the type and isotype of tested antibodies, the method of antibody detection, and the performance of saliva testing, saliva serum correlation, and association of saliva testing with clinical features.
So, Raju, with this review, the authors did a great job. The problem is that there are only 18 studies and so many different autoantibodies measured. So, how can we have a conclusion with this?
I entirely agree with you, and I knew that you will spot that with 18 studies and so many parameters to study. Obviously, the study design would not be really very uniform. But let's just focus upon some of the autoantibodies that they studied uh, across some rheumatological illnesses. They also had liver disease, endocrine disease, and celiac disease.
I could note that rheumatological disease included lupus, Sjogren, systemic sclerosis, and APLA. So I was glad that the shortlisted studies had also healthy controls. And Raju, what about the techniques applied and some more technical factors?
So, out of the 18 studies, 12 studies had used ELISA, and then there was RIPA in two and indirect immunofluorescence in two. These were the commonest techniques. In terms of the isotype studied, IgG antibodies were by far the commonest, followed by IgA. And interestingly, some of the studies also described the type of saliva collection and passive drooling, which was preceded by restriction in eating or drinking or brushing, were described. All samples that were collected were centrifuged before analysis.
Raju, like you, I read the paper with a lens. The problem is that the analysis is confusing and the discussion itself raises a self criticism. For example, IgA is very present in the mucosa. Can that affect the result? This is a question. And we have also unanswered questions about ideal sample collection technique and timing lab methodology, standardization, validation in a disease like Sjogren, where saliva is reduced, and isotypes to be studied and limited data on sensitivity and specificity. So there is a lot of question from this paper.
True. But most studies did show good saliva serum correlation and between the presence of disease specific antibodies with clinical features, at least in lupus and rheumatoid arthritis.
I'm sure that in the days to come, more studies will add to the data to this potentially very helpful procedure. Thank you very much for bringing this, Raju.
I like the word potential very much, Michael. I always believe that difficult problems have easy solutions. Maybe someone listening to this podcast will come out with an answer in the future.